So, hello, welcome to this week's clinical case. If you're a regular to my channel, you might have noticed that I like to have a certain theme for each clinical case. Last week's was obturating well, and this week is apex locator techniques, or we're doing a more in-depth look at how I use an apex locator, and I use a wireless apex locator. So I've got many different locators, but the one I'm using at the moment is wireless, which I think is pretty good because, you know, I've got a glut of equipment, loads and loads of equipment, and sometimes I feel like, especially when we're taking an x-ray or having all these kind of wires sticking out and things, I think this wireless apex locator is just a nice little addition to my sort of armamentarium, shall we say. But today's clinical case, I'm going to speak to you about how I had a problem with my apex locator, a really common problem running that battery, and how that affects the accuracy of the working length measurement. And you know, if we look at the x-ray, it's a clinical case of an upper right 6. A patient had a filling on this tooth a few months previous. The tooth then was having symptoms, and then upon examination we found that the tooth was suffering from irreversible pulpitis. So obviously the patient was consented and he's decided to go ahead with the root canal treatment. So as always, we'll get on with the case. First thing we want to do is we're looking at this nice composite filling here, and we're going to have to unfortunately drill this nice composite filling out, and it's already been accessed by myself at previous appointments. Sometimes when I see patients for a consultation and they're in active pain, I will actually physically get inside the tooth and get a bit of a clean out. So I've dressed it here with non-setting calcium hydroxide and some PTFE tape. And when we look inside, we can see that there are obvious canal orifices here, so which is a good sign. We know we don't have to spend time looking for these canal orifices, and in the first instance what we want to do is we want to irrigate the cavity, or the access cavity, shall we say. And because the canal orifices are really wide, I think I'm going to go straight for a working length, and I always like to go for the palatal first. So I'm using a size 10K file here. Again, there is an argument to say maybe a 15 would make a better accurate measurement. And when I place the probe onto the hand file, which is placed in the palatal canal, the apex locator is just all over the place, and this is really annoying. Okay, and this can be for a number of reasons. It can be maybe because, you know, there might be a crack in the tooth, or maybe you've perforated. Usually when you've perforated and you put a hand file into a perforation, the apex locator screams 0 instantly, but this was all over the place, and it transpires that this apex locator isn't charged up enough. So what we've got to do in this case, we've got to kind of move the hand file around a little bit so we get that kind of sweet spot where it's working. And like I say, so you could just pull the hand file out, of course, and just charge the apex locator up, but obviously we all live and work to time. You know, would the patient be happy if you rebooked him just to charge up your apex locator? So although not ideal, you know, just moving the hand file around a little bit so you kind of get that sweet spot is probably better. So once we've reached that kind of sweet spot with the hand file, what I'm going to do is I'm going to place the probe back onto the hand file, and you can see here that I'm way over. And what I always like to do, deliberately push the hand file through the apex, and then I always back it up. So you can see here that we're starting to back it up, and we got to 0 here in the red. And once we're at 0, I like to push it back through again just to check, and that's where I know I'm at the 0 reading, and I obviously moved the rubber stopper to a reproducible point, which is the mesobuccal cusp, and then when we measure it here, you can see that we're at 22 millimeters. So that is our 0 reading on our apex locator. As you know, I like to use glide path files. I'm going to use this glide path file up to the 0 reading, so 22 millimeters. And this is, I believe, a Tooth Saver 1403. I'm going to make sure I'm going to give this canal a nice good shaping, and then we're going to re-irrigate, and then once we've shaped it with our glide path file, we're then going to go in with our master apical file. In this case it's a size 25 variable high flex, and then I'm going to measure this to minus 0.5 millimeters away from the 0 reading, and we do this because we like to account for the apical constriction. So some people may or may not shape up to the 0 reading. Personally, I think if you use your master apical file up to the 0 reading, you're going to push through the apex, you're going to destroy the apex microscopically, and then this is going to be difficult for you to obturate successfully. Okay, and obviously obturation and sealing, it has a significant effect on the prognosis of the tooth. And finally, once I've shaped the palatal canal, I'm just going to place a hand file in the palatal canal just to make sure we've still got patency. That's really important. We want to make sure that canal space is still open. So once the palatal has been shaped, I am now going to try and negotiate down the Distobuccal canal. Don't ask me why I've gone for the Distobuccal. Sometimes it's just feeling, and I'm going to again use my size 10K file to push this to length, and then I'm just going to place the apex locator probe straight onto the hand file, and the readings are quite wild. And again, I've got to kind of do that kind of moving around with the hand file to kind of get that kind of bit of a sweet spot. But we get to a point where we've got the sweet spot. I'm going to push the hand file past the apex, so we're over the apex, and I'm going to back it up, and I'm going to push it back in again, and then back the hand file back, and that is where we know we've got a completely inaccurate reading. You might ask me why I'm going to push my hand file through the apex, and what I would say is sometimes when you're using an apex locator, you might get a 0 reading, but if you keep pushing the hand file further, you're going to possibly sometimes get an extra millimeter or 2 millimeters still showing that 0 reading. So I like to push through and then bring it back so we know that that is the true 0 reading on the tooth. And then when we measure the Distobuccal reading, 0 reading, it's measuring at 20.5. And again, it's just the same protocol as before. We're going to use our glide path file at 20.5. We're going to shape our glide path file to the 0 reading. And of course, we're going to irrigate. Once we have shaped the glide path file to 0, we're going to use our master apical file minus 0.5 millimeters away from the 0 reading, which again is 20 millimeters. So the next canal we're going to try and negotiate is the mesobuccal, and sometimes it's difficult to get your hand file into the mesobuccal. It's one of those ones where the patient has to open really nice and wide if you want to keep the file nice and straight, and it kind of transpires that I'm not really negotiating down the canal space that I'd like to. So what I'm going to do is I'm going to just bring the hand file back, and then I'm going to get my master apical file, I'm going to set it to 16 millimeters, and then I'm just going to use this as kind of an orifice opener. Of course, I could use an orifice opener, but this is more cost effective for you in the practice. So I'm just going to make sure I'm going to open up the canal space as much as possible in the coronal third. We're going to do lots and lots of irrigants, and now when we use our hand file down the mesobuccal canal, we are getting down nicely. We're going to negotiate nicely. So again, we're going to place the probe onto the hand file. I've charged it up a little bit since the last working length measurement, so this is working a little bit better. Same again before, I'm going to push it through the apex ever so slightly and back it up, and then as I back it up, I'm going to move the stopper, pull the hand file out, and I'm going to measure it, and I feel like this is the most accurate reading that you can get as you back the file out. And when we get our mesobuccal canal 0 reading, it's measuring at 19 millimeters, and again, it's all about repetition. It's the same thing. We're going to use the glide path file to 0. We're going to use our master apical file minus 0.5 millimeters away from the 0 reading, and What I notice here is that obviously this this master apical file is going to length, but when I recapitulate with my size 10K file, it's not quite getting to length, which means that possibly using the size 25 has ledged the tooth ever so slightly. So this is an argument to say maybe going from a size 10 or 15 glide path up to 25 might be a bit too much. So the way I'm going to try and get around this, I'm going to make a tiny little bend in the size 10K file. Again, it transpires that this doesn't quite get past. You obviously want to have patency, because when you come to obturate the tooth, obviously you want the whole length of the tooth to be obturated and sealed off. Because I can't quite get to length of the size 10, I am going to use my glide path file in T mode. And again, I'm just not pushing this too far. Sometimes this glide path file in T mode, which is kind of reciprocation motion, gets past this little bend, but it doesn't. And then finally, I'm using a size 8 D finder, and I put a little bend at the end, and I managed just to get myself slipped in past the ledge that's been created, and I'm just going to push it in and out. Nice easy movements. Again, I've said before, if you bypass a ledge with a hand file, you don't want to bypass it and pull it straight out. You want to kind of use this sort of in and out motion to try and sort of smooth off that ledge as much as possible. And once I feel like that I have smoothed off the ledge as much as possible, I'm going to go step in with my size 10 K file with, again, the tiny little bend at the end. And as I push this size 10K file to length, it does again slip nicely past the ledge part. And then once I've passed the ledge again, I'm going to just do a little bit of in and out movement. Again, just take your time with this, because what you could do is you could make the ledge worse, which is obviously not what you want to do. And then I'm going to move up with my glide path file. Again, I'm going to use T mode, but again, it just shows that I'm not quite getting to length with the glide path file. So it's at this point I'm thinking to myself, I'm just gonna leave it well alone. Okay, I know that the Canal is patent because I've got patency with the size 10K file, but what I don't want to do is I don't want to create a further ledge or a blockage, and obviously I don't want to separate the instrument in the Canal. So what I'm going to rely on, and you'll see later, is that when I come to obturate the tooth, I'm going to rely a bit more on this sealer to get into that kind of difficult part of the root canal, which my rotary files don't get quite to length. It's at this point I've got to think to myself now, it's an upper 6, there's a very high chance that's an MB2, and I look here and there's this kind of dentine shelf, as we'd like to call it, and what you want to do is when you're looking for MB2 is you want to remove this dentine shelf, and you can do this anywhere. You can use high energy ultrasonics, or you can use a fast handpiece. I always think using those two methods is quite difficult and can be quite dangerous as well. So in my case, I like to use a low energy ultrasonic unit, and you can see here that we've removed that dentine shelf and it's exposed that MB2 canal. And in the first instance, I'm just going to use a size 10K file to try and negotiate down that canal, but I'm struggling slightly to get this K file down the canal. We're getting a little bit of negotiation, but nothing too major, so I'm going to pull that out. I'm not going to push it any further, and we're going to use this 8D finder. And this 8D finder, again, as we negotiate into the coronal third of this MB2, it is getting a little bit further than the size 10K file, but it is getting a little bit stuck. So what I'm going to do is I am going to use my glide path file about 1 millimeter away from us, the furthest point that we've got. Again, I'm just going to shape out this coronal to mid-third portion of this canal space, and then I'm going to do the same trick I used with the MB1, is I'm just going to use my master apical file, this 25 variable file, just as kind of like an orifice opener to try and open up the coronal third of this MB2. Once we've opened up the coronal third, we're going to use this size 8 D finder again, and I'm just going to slowly push it down. Again, it's slipping really nicely to length, but it's getting a little bit stuck. I put the apex locator on, and again, it's a little bit all over the place because it's low of battery, and we're not quite getting to the working length. We're not getting a 0 reading here, and the first thing that I'm thinking is do the MB1 and the MB2 join. So what I'm going to do is I'm just going to pull this definder out, and you can see here actually, as you pull the definder out, it's kind of got that weird sort of S shape, hasn't it? And you can kind of sort of squint your eyes and sort of imagine that maybe this looks like this is a canal that's joining onto another canal. So always in your back of your mind, have a little think about that. Also, what you've got to think in your back of your mind is that this this canal might have its own portal of exit. So don't cross off all of your eventualities just yet. Just make sure, just have sort of a differential diagnosis in the back of your mind. And as we measure it here, we can see that we're about 19.5. So I'm going to get my glide path file, and I'm going to measure it to about 19 to 18.5, and I'm going to see if I can shape out this canal space even further. Once we've used the glide path file, I am going to use my size 25 variable high flex master apical file, and as I am sort of negotiating this rotary file to length, I just feel like I'm getting stuck. Okay, I feel like that there may be a join, and what I'm going to do here is I'm just going to get my rotary file, and I'm going to measure to how far we've got with this rotary file to see that's kind of where the join might be. And as we measure it here, we can see we're about 15. And in fact, when we come to irrigate and aspirate the canal spaces, specifically the MB1, the MB2 also irrigates and aspirates at the same time. So this is a strong indication to me that the MB1 and the MB2 join together. So we're ready to take our cone fit radiograph essentially. And when we come to do our cone fit radiograph, we're going to measure the cones. We're going to take the 0 reading. We're going to minus 0.5 millimeters away from this 0 reading, and then we're going to measure our cones to this point. We push them to length, and we make sure that the sort of bend that you've made in the GP cones goes to that kind of reproducible point, and then we're going to cut them off. Don't forget the tug back. And then when we look at the cone fit radiograph here, it looks great. We've got a nice kind of fluted kind of shape on the cones where they're sort of moving nicely within the roots, and then obviously all of the cones are at or within the acceptable range of the radiographic apex. And then that's kind of the hardest thing done. We're going to use our final irrigation protocol. Again, I use sodium hypochlorite, 2%, and now I've started to use 5% as well. We're going to activate that. We're going to use 17% EDTA, activated, and again back with our final wash with sodium hypochlorite, again always activating. And then we're going to just dry the canal spaces with our paper points. And then we're ready to obturate. I am going to use a bioceramic sealer here. In this case, I'm using 1 fill. We're going to fill the palatal canal here within the mid-third or coronal third with sealer. Then what I like to do is I like to confirm patency, or just open up this with a hand file just to make sure we don't get any of this vapor lock, shall we say. So I'm sort of introducing the sealer all the way to the apex, and once we have done that, we just place our cone to length very, very slowly, not going to ram it home like I always say, and once we just push it nicely to length, we're going to use a heated plugger just to remove the excess. And it's the same protocol for all the other canals. And then when we look at our cone fit radiograph, again, it looks fantastic, looks beautiful. Now, to the eagle-eyed viewers here, you might notice something which I don't often do, and this is a significant sealer puff in all of these canals. You know, if I'm really, really honest with myself, and I do hundreds of root canals a year, I am still getting to grips with the amount of sealer that I should use during obturation, and I would say 99% of the time I feel like I use an appropriate amount, but in this case I have, you know, caused a significant extrusion with our sealer. And when I say significant, I will suppose maybe I'm being a little bit, I'm exaggerating slightly there. It isn't significant. We've got kind of that kind of mushroomed sort of effect with the sealer where it's sealing the end of the tooth. I think if I was honest with myself, I don't want this type of extrusion. But then I spoke to my really, really good friend who's a consultant endodontist at Liverpool, and he sort of laughs and he says he's not really that bothered about extruding materials out the end of the tooth. I suppose he's got a little bit more latitude because he is a super specialist. But I think in my case, I am not worried really about sealer going out the end, especially bioceramic sealer, because it's going to resorb away, or it should resorb away. But I think really my issue here is this is an external referral. This might have been a referral from a new dentist who's never referred to me before. And, you know, I don't know what their perception is of a good root canal. And, you know, in my mind, I know this is a good root canal. But what I want to sort of convey is that it looks good as well. And I know that sounds really sort of superficial, but it's really, really important, especially if you're on your the early days of your endodontic career. You want to make sure that you obviously want to do best for the patients, and you want to communicate well with the patients, but also you want to communicate well with the referring dentist, because essentially they're your bread and butter. You want to keep them happy. And yeah, that's it. Perfect. Another Friday, another case. If you love the video, please like and subscribe. If you feel like you would have done something different, or something wrong's been done, or you have any criticisms at all, I welcome criticism. So comment in the section below. I'll always try to comment back. And if you really, really love the channel, you become a member of the channel. The membership is a small monthly fee. You get to support the channel, makes me independent. And also as well, if you comment in the section below, I will reply to you with a video short, and that will be posted in the members area. It also gives you early access to content as well. So I'm usually about 2 to 3 weeks ahead with posting these, so they're scheduled. And if you're a member, you get to see them, you know, 2 or 3 weeks ahead. Overall, thanks for watching, and I'll see you in the next video. Bye bye.